Vecuronium. Vecuronium. Neuromuscular blockade with Vecuronium. ICU, anesthesia, and emergency medicine perspectives. Introduction. 1. Vecuronium is a non-depolarizing neuromuscular blocker (NDNMB) of the aminosteroid class, with intermediate duration of action and minimal cardiovascular side effects. 2. It is used to facilitate endotracheal intubation, provide skeletal muscle relaxation during surgery, and maintain paralysis in mechanically ventilated ICU patients. 3. Compared to Rocuronium, it has a slightly slower onset but similar duration, and unlike succinylcholine, it is free from depolarizing side effects. Definition. According to World Health Organization (WHO), Vecuronium is a competitive nicotinic acetylcholine receptor antagonist at the neuromuscular junction that prevents depolarization, resulting in skeletal muscle relaxation without fasciculations. Vecuronium is a competitive nicotinic acetylcholine receptor antagonist. It blocks acetylcholine at the neuromuscular junction. This blockage prevents muscle depolarization, resulting in skeletal muscle relaxation without fasciculations, muscle twitches. History. Developed in the 1970s as a derivative of pincuronium with less cardiovascular effect. Introduced into clinical practice in 1980. Quickly became popular in anesthesia due to its stability and low incidence of histamine release. Classification of Vecuronium. 1. Pharmacological class. Non-depolarizing neuromuscular blocker, NDNMB. It competitively blocks acetylcholine receptors at the neuromuscular junction, preventing muscle depolarization. 2. Therapeutic class. Skeletal muscle relaxant, aminosteroid type. It induces muscle relaxation by blocking nerve impulses, making it useful for surgery, intubation, and mechanical ventilation. Chemical properties. 1. Chemical name. 2-beta, 3-alpha, 17-beta, -17-acetoxy-3-hydroxy-2, 1-piperidino, androstan 16-YL1, 2-propenyl, pyrrolidinium bromide. 2. Molecular formula. CHBRNO. 3. Molecular weight. 637.74 grams per mole. 4. Structure. Monoquaternary aminosteroid derivative of pincuronium. 5. pKa, approximately 8.0. Physical properties. 1. Appearance. White to off-white crystalline powder, lyophilized. 2. Solubility. Freely soluble in water when reconstituted. 3. Formulation. Supplied as lyophilized Vecuronium bromide for reconstitution with sterile water or compatible IV fluids. 4. Stability. Refrigerate. Stable at room temperature after reconstitution for a limited period, usually 24 hours. Mechanism of action. 1. Competitively binds to nicotinic acetylcholine receptors at the motor endplate, preventing acetylcholine from triggering depolarization. 2. No depolarization phase. Results. No fasciculations or potassium release. The effect is reversed by acetylcholinesterase inhibitors, e.g., neostigmine or sagamodex. Pharmacokinetics. 1. Onset. 2 to 3 minutes, intubating dose. 2. Peak effect. 3 to 5 minutes. 3. Duration. 25 to 40 minutes, dose dependent. 4. Distribution. VD approximately 0.2-0.3 L per kilogram. 5. Metabolism. Hepatic distillation to active metabolite, 3-decacetyl Vecuronium, prolonged action in hepatic dysfunction. 6. Elimination. Primarily biliary excretion, approximately 4–60%, renal excretion, approximately 20–30%. 7. Half-life. 65 to 75 minutes, prolonged in hepatic, renal impairment. Pharmacodynamics. 1. Produces profound skeletal muscle relaxation without histamine release. 2. Minimal cardiovascular effects, no significant vagolytic or sympathomimetic activity. 3. Slightly slower onset than Rocuronium. Storage and disposal. 1. Store vials refrigerated 2 to 8 degrees Celsius. 2. Protect from light. 3. Discard unused reconstituted solution after manufacturer specified period. 4. Dispose per hospital hazardous waste protocols. Interactions. 1. Potentiated by volatile anesthetics, aminoglycosides, magnesium, lithium. 2. Antagonized by cholinesterase inhibitors, if no sagamedex used. 3. Additive effects with other non-depolarizing agents. Clinical uses. 1. Facilitation of endotracheal intubation, non-emergent or controlled settings. 2. Skeletal muscle relaxation during surgery. 3. Maintenance of paralysis in ICU for mechanical ventilation, e.g., ARDS. 4. Neuromuscular blockade in patients intolerant to histamine-releasing agents. Use in ICU. 1. Used for prolonged sedation and paralysis in ARDS, refractory status asthmaticus, or to improve ventilator synchrony. 2. Preferred when hemodynamic stability is important. 3. Risk of ICU-acquired weakness with prolonged infusion. Use in anesthesia. 1. Provides stable muscle relaxation during surgery. 2. Often chosen for patients with cardiovascular disease due to minimal effects on BP or HR. 3. Suitable for maintenance in long procedures. Use in emergencies. 1. Can be used for rapid sequence intubation if succinylcholine contraindicated and rocuronium unavailable, but onset is slower 2-3 minutes. 2. Not the first choice in critical airway scenarios requiring immediate paralysis. Administration and dosage. 1. Adults. 1. Intubation. 0.08-0.1 mg per kilogram IV, ed 95 equals 0.05 mg per kilogram. 2. Maintenance. 0.01-0.015 mg per kilogram IV bolus or infusion 0.8-1.2 microgram per kilogram per minute. 2. Children. 1. Similar milligram per kilogram dosing. Neonates may require lower doses due to prolonged action. Common side effects. 1. Mild injection site discomfort. Discomfort or pain at the site of injection. 2. Muscle weakness. Prolonged muscle weakness or paralysis. 3. Hypotension. Low blood pressure, which may be more pronounced in patients with pre-existing hypotension. 4. Tachycardia. Increased heart rate. 5. Hypersensitivity reactions. Rare allergic reactions, including anaphylaxis, can occur. Serious side effects. 1. Prolonged neuromuscular blockade in hepatic, renal failure. Because Vecuronium's elimination is dependent on liver and kidney function, impaired function can lead to prolonged blockade. 2. Anaphylaxis, rare, due to hypersensitivity reaction, which can be life-threatening if not promptly treated. 3. ICU-acquired weakness with prolonged use. Prolonged paralysis can lead to muscle atrophy and weakness, making it challenging for patients to recover. 4. Respiratory failure if extubated before full recovery, because patients may not have sufficient respiratory muscle strength to breathe on their own, leading to respiratory failure if extubated too early. These serious side effects highlight the importance of careful patient selection, monitoring, and dosing when using Vecuronium. Contraindications. 1. Known hypersensitivity to Vecuronium or other aminosteroid NMB because an allergic reaction can occur, potentially leading to anaphylaxis or other severe reactions. 2. Situations where rapid reversal is not possible and patient is ventilated, because Vecuronium-induced paralysis can lead to respiratory failure if the patient is not adequately ventilated, and inability to rapidly reverse the paralysis can be life-threatening. These contraindications highlight the importance of careful patient selection and preparation before administering Vecuronium. Precautions. 1. Reduce dose in elderly, hepatic, or renal impairment, because these patients may have reduced metabolism or excretion of Vecuronium, leading to prolonged paralysis or increased risk of side effects. 2. Continuous neuromuscular monitoring advised. Avoid overdose, to prevent excessive neuromuscular blockade, which can lead to prolonged paralysis, respiratory complications, or other adverse effects. 3. Avoid unnecessary prolonged use in ICU, because prolonged paralysis can lead to ICU-acquired weakness, muscle atrophy, and increased risk of respiratory complications, making it harder for patients to recover. These precautions highlight the importance of careful dosing, monitoring, and management when using Vecuronium to minimize risks and optimize patient outcomes. Advantages. 1. Minimal cardiovascular effects, because Vecuronium has a stable hemodynamic profile, reducing the risk of cardiovascular complications during surgery. 2. No histamine release. Vecuronium doesn't trigger histamine release, which can cause hypotension, bronchospasm, or other allergic-like reactions. 3. Intermediate duration allows flexible intraoperative use. Vecuronium's duration of action is long enough to provide adequate muscle relaxation during surgery, but short enough to allow for flexible use and timely recovery. 4. Reversible with Sagamidex or acetylcholinesterase inhibitors, because Vecuronium's effects can be rapidly and reliably reversed, allowing for quick recovery and reduced risk of postoperative respiratory complications. These advantages make Vecuronium a popular choice for neuromuscular blockade in surgical settings. Disadvantages. 1. Slower onset than Rocuronium or succinylcholine, because Vecuronium takes longer to achieve peak effect, which may not be ideal for situations requiring rapid muscle relaxation. 2. Active metabolite may prolong blockade in organ dysfunction. Vecuronium's active metabolite, 3-decacetyl-Vecuronium, can accumulate in patients with liver or kidney dysfunction, leading to prolonged neuromuscular blockade. 3. Not ideal for emergent rapid sequence intubation (RSI*). Due to its slower onset time, Vecuronium may not be the best choice for emergency situations where rapid muscle relaxation and intubation are critical. These disadvantages highlight some limitations of Vecuronium, emphasizing the need for careful consideration of its use in specific clinical situations. Clinical considerations. 1. Best for elective or controlled airway settings, not emergency RSI, because Vecuronium's slower onset time may not be suitable for emergency situations where rapid airway control is necessary. 2. Use with Sagamidex allows rapid reversal from deep blockade. Sagamidex's ability to rapidly reverse Vecuronium-induced blockade provides flexibility and control in clinical settings, reducing the risk of prolonged paralysis. 3. Train of 4 monitoring essential for titration in ICU and OR. Train of 4 monitoring helps clinicians assess the degree of neuromuscular blockade, allowing for precise titration and minimizing the risk of overdose or underdose, which can impact patient outcomes. These clinical considerations highlight the importance of careful planning, monitoring, and management when using Vecuronium in various clinical settings. Vecuronium versus other agents. Onset time. Vecuronium, 2 to 3 minutes. Rocuronium, faster, 1–1.5 minutes. Succinylcholine, fastest 30 to 60 seconds. Atracurium, similar to Vecuronium, 2 to 3 minutes. Duration. Vecuronium, intermediate 25 to 40 minutes. Rocuronium, intermediate to long 30 to 60 minutes succinylcholine, short 5 to 10 minutes atracurium, intermediate 20 to 35 minutes. Reversal. Vecuronium can be reversed with neostigmine or Sagamidex, succinylcholine. No reversal agent, just wait for it to wear off. Atracurium can be reversed with neostigmine. Side effects. Vecuronium and Rocuronium. No histamine release. Succinylcholine can trigger malignant hyperthermia, MH. Atracurium, mild histamine release possible. This comparison highlights key differences between these neuromuscular blocking agents, helping clinicians choose the best agent for specific situations. Additional information. 1. A close analog of Rocuronium with slower onset but slightly shorter duration in some patients. 2. ED95 equals 0.05 mg per kilogram, intubating dose is approximately 2 times ED95. 3. Sagamidex dose for immediate reversal from deep blockade, 16 mg per kilogram. Current trends. 1. Vecuronium is still widely used in anesthesia, particularly when cardiovascular stability is crucial, because it has minimal cardiovascular effects. 2. However, its use is being replaced by Rocuronium for rapid sequence intubation (RSI) in many centers due to Rocuronium's faster onset speed and the convenience of Sagamidex reversal. 3. Vecuronium remains valuable for long surgical cases with planned, controlled intubation because longer duration, cardiovascular stability, and effective reversal. Current research trends. 1. Comparing postoperative residual blockade rates. Ongoing studies are investigating the rates of postoperative residual blockade, PORB, associated with Vecuronium and other neuromuscular blocking agents, NMBAs. PORB can lead to respiratory complications and prolonged recovery times. Researchers aim to identify the most effective and safest NMBAs for surgical patients. 2. Reducing ICU-acquired weakness. There's growing interest in using combined low-dose strategies to minimize ICU-acquired weakness, a common complication in critically ill patients. By optimizing dosing protocols and combining Vecuronium with other agents, clinicians can reduce the risk of muscle weakness and improve patient outcomes. Conclusion. 1. Vecuronium is a safe, stable, and versatile non-depolarizing muscle relaxant best suited for controlled intubation and intraoperative use where minimal cardiovascular impact is important. 2. While it is less ideal for emergency RSI due to slower onset, it remains a reliable choice for elective surgical and ICU settings. Vecuronium is the quiet professional of neuromuscular blockers, steady, predictable, and dependable when the airway is secure and time is on your side. Anesthesia's safety principle. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.